Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts and powered by Encore Research Group.
Hi, I'm Al Lopez. I'm happy to be on MedEvidence and really thankful for Dr. Corrin and the group to allow me to speak with you today. I'm a general internist. I specialize in lipids and diabetes, but kind of the general contractor of medicine. Today I'm going to speak to you about diabetes and new emerging therapies or new therapies um, and their benefits in diabetes. We've known diabetes has been a big risk factor for cardiovascular disease. In fact, we know that patients that have elevated blood sugars have 2 to 3 times higher risk of developing heart disease. But the diabetic has a markedly higher increase of risks, which includes 4 to 6 times higher risk of heart attack and stroke, a much higher risk of developing kidney disease. Kidney disease is also known to be a risk factor for cardiovascular disease, so that increases the risk again. We know there are other complications of diabetes, which include eye disease, or what we call retinopathy, neuropathy, or nerve damage in the feet, um, as well as gastroparesis, or delayed emptying of the stomach. So people feel bloated, don't feel comfortable, and often are constipated. But those are more nuisance complications. The real complications that we really wanted to fix from the beginning has been cardiovascular disease, heart attack, stroke, arterial disease of the legs, as well as renal disease or kidney disease. In the past, we've had lots of good drugs. In the beginning, there were insulins, which kind of mimicked how we release insulin from our own body in an organ called the pancreas. And we've tried to mimic how that insulin is released. But when you're doing injections, that becomes really hard because the insulin is secreted on a long-term basis and not just in little bits where you have to give yourself injections. So that really didn't mimic the normal body. Then we've used certain drugs which are not in favor anymore, and some that are still out there like sulfonylureas, which are not a favorite for many physicians anymore because whether you eat or don't eat, they lower your sugar, and hence people can get hypoglycemia or low sugars and feel really badly, have shakes, visual issues, and might even pass out and fall and have to be hospitalized. So we tend not to like to use these drugs much anymore. Um, they also, unfortunately, increase atherogenesis or heart disease, and they also increase kidney disease. We then found other drugs like metformin, which has a benefit and has a mild cardiovascular benefit. Also do not cause lowering of blood sugars, which was a big advantage. So people didn't have these horrible sugars if they missed a meal. Um, we then developed drugs like DPP-4s, and those drugs were really easy because you didn't have to dose unless you had end-stage kidney disease, the dose of the drug, and hence it was just easy. You just gave them a dose, carried on. We had about a 0.8% drop in A1C, which is a marker we look for diabetes to see if you're controlled. Then the TZDs came out. There was a lot of controversy with them. They do have a benefit for mild stroke reduction, but unfortunately, in higher doses, we had a significant amount of weight gain, water weight gain. People would bloat, have leg swelling. But those patients with congestive heart failure, unfortunately, flipped into congestive heart failure on the higher dosing. So we tend not to use these drugs in patients with known congestive heart failure. And then lastly, we developed these long-acting insulins, basal insulins we called them, which also kind of changed the game. But in the last few years now, we have two incredible drugs which changed the whole landscape of diabetes. And in the past, we had drugs that lowered sugar, and they didn't help with weight loss or didn't help with your blood pressure and didn't really kind of help with complications of diabetes. The theory and the feeling was if you lowered blood sugar, you'd improve these outcomes and you did better. but that was probably not necessarily the case we're finding today. So today I want to introduce my two new friends in diabetes, two classes of drugs called SGLT2 inhibitors, which there are four of in the class, and I understand there's a fifth one coming out of the market. And we have the GLP-1 inhibitors. And so I like to talk to them because now we change the landscape in that we just don't lower sugars. Now we have protective benefits of these drugs, which include cardiovascular benefits, reduction of all-cause mortality, reduction of heart attack, reduction of stroke, potentially reduction of arterial disease of the legs, weight loss, drop in blood pressure. We also have reduction in poor kidney outcome and improvement of kidney outcome with some of these drugs. So let's get started. I'm going to first talk about the GLP-1s, which I think is a great class, and I'm going to save my most favorite class for a second. GLP-1s are the glucagon-like peptide 1 receptor agonists. And these are drugs that actually talk to the pancreas. And the pancreas is the organ that releases insulin into our bloodstream and help us reduce blood sugars. They're interesting because they work best when you take an oral insulin. So not by IV so much, not by IV or other methods, but as you take in oral sugars or too much sugars, your body doesn't compensate well with it. It regulates blood sugars by releasing certain gut hormones, and there are certain receptors in the stomach or the intestine actually that release this peptide and hence starts dropping blood sugars and releases insulin. And again, it works best by oral ingestion of glucose, whether it be sweets, simple sugars, excessive carbohydrates, and that amount is dependent on the individual and how insulin resistant or how quote unquote brittle or diabetic that person is. There's several in this class. In fact, there are 6 and one that's kind of a GLP-1 and 2, tirzepatide, which is relatively new. I'll mention tirzepatide because it's the only one in that section of GLP-1s. Mounjaro, it's called. And it's a great drug. It does have some weight loss. It does control sugar very well. But to this date, there are no outcomes for kidney disease or cardiovascular outcomes with this drug. But it seems promising at this time. If we look at the benefits, the main benefit it has is reducing sugars and weight loss. But in most cases, in most of these drugs, there is a reduction in atherogenesis or cardiovascular disease or reduction of rate of heart attack. And we think that happens because there's less oxidative stress within the system. There is less platelet or the sticky things that make us stop bleeding, less platelet activation, so we don't clot as easy. We think that there's less white cells that go into the arterial wall. There's inflammation in the arterial wall, and we're developing plaque or have erosion in arterial walls. And because of that, there's less plaque formation or there's less clotting and there's less events because of that. We also think there's a stabilization of vulnerable plaque in the arterial wall where that plaque may actually solidify itself and become more stable and less likely to rupture and have a sudden heart attack or event. And best, it actually stabilizes endothelial cells, which is the inner lining of the arterial wall, which is that inner lining of the arterial wall, that endothelium is what is markedly oxidized. It becomes weak because of high sugars. There are several studies that we can talk about with cardiovascular outcomes in this class. There's REWIND, there's SUSTAIN 6, there's LEADER, ELIXA, EXCEL, and PIONEER 6. And unfortunately, only some of these drugs have shown reduction of cardiovascular events. REWIND with glepaglutide has a 12% reduction of cardiovascular events and a 24% reduction of non-fatal stroke. Sustain, which is semaglutide or Ozempic, that showed a 26% reduction in cardiovascular events and about a 40% reduction in stroke or non-fatal stroke. Victoza or Lagritide has shown a 22% reduction in cardiovascular events with no significant reduction in stroke. Elixa, which is Soliqua, has showed no real benefit statistically, so that has shown no either heart or stroke benefit. Excel, which is Bydureon, showed a 9% reduction in cardiovascular event, but um, no non-fatal stroke data. And Pioneer 6, which is oral semaglutide, and most of these drugs, all the other drugs are injectables, but Rybelsus or oral semaglutide has a 21% reduction in cardiovascular event, but no significant reduction in non-fatal stroke. What's interesting, Rybelsus, which has been the only oral one in its class, may not be the sole child soon. It looks like there'd be another one coming in, which we're about to do studies on in the next year. When we look at renal outcomes, I can mention the studies. It's a Ward 7, Leader, and Rewind with several of the drugs, 3 of the drugs. But unfortunately, none of them really have shown a very large statistically significant reduction in renal protection or renal disease. Most of them will decrease microalbumin, which is this microscopic protein, which diabetics tend to secrete and tends to clog up the kidney. So basically, the kidney is your filter, and it basically clogs up your filter and no longer functions really well, and you get a chronic kidney disease or more damage to the kidney. At most, we've seen really push the data, maybe about a 10 to 18% reduction in microalbuminuria, this microscopic protein, but long-term protection is not really seen with it, unlike what we see in SGLT2 inhibitors. There is a marked weight loss benefit with this class of drugs, some more than others. It tends to decrease energy intake. It decreases food craving, increases a sense of satisfaction that you're full easier or satiety, and it does suppress appetite. By far, semaglutide outweighs the others. Mounjaro seems to come close with about a 14% weight loss, but we can use these drugs in combination with other medications, including SGLT2 inhibitors for weight loss. And only one semaglutide or Ozempic has been shown to get FDA approval for weight loss on non-diabetics. The big benefit is these drugs, as I mentioned before, don't drop blood sugars unless they're combined with insulin, so we have to reduce the insulin load, or if we're using sulfonylureas. But for the most part, we don't have lows, so we're able to use these drugs, or at least some of them, in diabetics as well as non-diabetics. So like any drug, there's adverse events. What is the great things about this drug? Well, you can develop nausea, vomiting, or diarrhea with these drugs, or GI side effects. Mainly in type 1 diabetics, the ones that are more insulin dependent, that really don't have insulin function or secretion, they can develop pancreatitis. The percentage is very small, but it can occur. In one of the drugs, semaglutide, there's an increased rate of retinopathy or eye disease, irrespective of how well the sugar is controlled. There is very little hypoglycemia, as I mentioned before. And there is an incidence of medullary thyroid carcinoma, or a possibility of it, but we have not seen this in humans. It's mainly been in the original studies done on rats. What's exciting is we may have potential new benefits for this drug or this class of drugs. Non-alcoholic fatty liver, which is a disease that we've not found good drugs to fix. We've tried a number of medications, statins, metformin. We've tried diabetes medications, and to date, except for one new drug that's coming out, which we've done the research on at Encore Research, as well as other sites across the country, um, weight loss and controlling fat intake has shown minimal benefit. But this drug looks to be promising and maybe slowing progression of non-alcoholic fatty liver disease. In polycystic ovary syndrome, classically we've used metformin. Other drugs have failed. Weight loss has done great benefits with women that have polycystic ovary syndrome, but this drug may show promise in one or two of the drugs in this class, but we need to do new studies to see if it really is that effective. And again, we try not to use it in type 1 diabetics because of the risk of ketoacidosis. So now we move to the second class that I wanted to talk about today, and that would be the SGLT inhibitors. A very, very versatile class, which has multiple benefits. It is a diabetic drug, but again, as I mentioned, the old drugs had some minor benefits, but the SGLT2 inhibitors seem to have a marked benefit. So we'll talk about the SGLT2 inhibitors at this time. This is a very versatile class, which shows multiple benefits for multiple organ systems. Whereas I mentioned before in the past, we had drugs that lowered sugar and only lowered sugar and had minimal benefit. Now we have drugs that have multiple benefits. There's nothing better than achieving multiple benefits with one drug. What's interesting is that it could be used as first-line therapy or the GLP-1s, but mainly to use the second or first-line therapy with or without metformin. And this drug works on the kidneys, on what we call the renal tubules. So generally, when your sugars are high, we tend to want to retain more sugar. This drug actually allows us to excrete sugar in the urine. In the past, 30, 40 years ago, excreting sugar in the urine was not a good thing. It meant you were really uncontrolled diabetic, and it basically raised most providers' hairs on straight up in the air, almost like Bozo the Clown. But we find that today this is a huge benefit, and that if we can release the sugar in the urine, there's a marked benefit on sugar control, but there are potential side effects in doing that, including bladder infections, fungal infections in the groin area, genitourinary system. But for the most part, there's marked benefits in this class of drug. This class of drug can actually drop A1Cs with the 3-month marker for diabetes anywhere from 0.6 to 1.2, 1.4%, which is a pretty significant drop. Again, this drug, as in the GLP-1s, shows very little lowering of sugars and having hypoglycemia, unless, again, they're used with insulin or sulfonylureas. But there are marked benefits in the cardiovascular realm and in the kidney realm. Again, I've mentioned there are 4 in the class currently out on the market. 3 have shown benefit, and there were several cardiovascular outcome studies that came out late 90s, early 2000s. There was the Canvas trial with canagliflozin, which showed marked reduction in hospitalization for congestive heart failure but did not really show a statistically significant major adverse cardiovascular event or MACE event. We do have Empareg, which is a canagliflozin, which did show benefit, as well as Declare TIMI 58, which was shown with dapagliflozin, and that also showed benefit. But unfortunately, Veritas CV with eruticaflozin, which is the one drug in this class, has not shown major cardiovascular nor renal benefits. So I'll focus most of this talk on, or this part of the talk, on the first 3, panagliflozin, canagliflozin, and dapagliflozin. There was a definitive reduction of hospitalization for congestive heart failure anywhere between 33 and 39 and 42% with the prior three drugs I mentioned. This is a major issue because a couple of the major side effects of diabetes is, as I mentioned prior, cardiovascular disease is majorly increased in diabetics. Congestive heart failure, 67% of diabetics will develop congestive heart failure in their lifetime if they're not properly treated. And this leads into really poor outcomes, poor lifestyle, and obviously death. And the renal demise eventually that occurs with diabetes, if it's not controlled, there seems to be a stabilization of renal function and protein elimination through the kidneys or improvement with this drug. Only one, canagliflozin, has shown improvement of renal function. Again, we think that the cardiovascular benefits may occur because there is a decreased inflammation in the arterial wall, as we saw with GLP-1s. There's a change in the lipid profile or cholesterol profile, mainly in ApoB or LDL particle number and particle size. Endothelial dysfunction, which I mentioned before, the endothelial and aligning of the arterial wall often becomes rusted out or becomes thin, becomes more prone for rupture in diabetics and with higher oxidative stress. And we'll see higher oxidative stress in elevated blood sugars, smokers, patients that are overweight or obese, or people that eat highly refined sugars, or people that eat fast foods or highly processed foods. So it tends to decrease the endothelial dysfunction in these patients. We'll see less oxidative stress, less white cells that come to that area of inflammation and therefore make that wall a little more dysfunctional, less oxidation of the LDL and less foam cells, and then the plaque or the buildup of soft, goopy atherosclerotic plaque seems to stabilize, and the size of it seems to reduce and stabilize and become less prone to rupture. So we think these may be the potential outcomes of why that happens. And there's been 3 studies that have shown those mechanisms actually working, showing cardiovascular benefits. In looking at the renal benefits of the SGLT2 inhibitors, as I mentioned earlier, we have the EMPA-REG study, we have the CANVAS trial, we have the CLARITIMI trial, which all shown benefit. But unfortunately, as I mentioned, the Veritas CV trial has not shown benefit. There was a backup study as a composite group of all of these drugs. They didn't compare one versus the other, but they took the composite of these drugs in whole, and it's called the CVD Real trial. And that CVD Real 3 study actually showed that the 3 showed original benefit, showed probably even better benefit of cardiovascular outcomes and renal outcomes, despite the glucose lowering properties. So what I'm trying to say is that even if the sugar doesn't go down markedly, it still has a cardiovascular benefit. We've seen in 2 of these drugs, panagliflozin and dapagliflozin, that we've actually seen benefit in congestive heart failure even in non-diabetics. So because it doesn't tend to lower sugars in those that don't have high sugars or non-diabetics, the studies were done on these 2 drugs in congestive heart failure and non-diabetics, and it's shown tremendous benefit. Unfortunately, canagliflozin did not do this study, but there is discussion that between the 2 that are used in diabetics and non-diabetics, if you tease out the data, we think there may be protective benefits in preventing congestive heart failure from occurring in patients that are on this drug, whether they have high sugars or diabetics, or they're normal glycemic or normal sugars or non-diabetics. But those studies really are being looked at this time, but we cannot truly say that it has a true protective benefits. What's very interesting, it's not only shown benefit in those patients with reduced pump function, or what we call heart failure with reduced ejection fraction, their heart doesn't pump as effectively, that they have heart damage or myocardial damage, so that tissue doesn't really pump as well. But it also has been shown to occur in patients, at least with the DAPA trial, in patients with preserved ejection fractions. Those patients that, even though they have a normal pump function, they still retain fluid and have heart failure. And this is really novel because we really had a hard time controlling these patients and really getting them under control and reducing the rate of hospitalization in these patients. It was a lot harder for that to happen until recently. We do have other metabolic effects besides congestive heart failure, cardiovascular disease, and kidney disease. We do see weight loss in these patients. It's modest. It's not as much as the GLP-1s, but there is benefit with it. And actually, they've been trials with other weight loss reducing drugs, including GLP-1s, that augmented the amount of weight loss. So it can be used for weight loss, but it does not have the indication for weight loss. We have seen it drop blood pressure, so we see better control of blood pressure in these patients, and that's been a benefit of this class of drug as well. But as we saw benefits in non-alcoholic fatty liver disease, GLP-1s, we think that Apana and dapagliflozin and canagliflozin have all shown probably benefit in the reduction of fatty liver disease that does not occur from alcohol ingestion. And that may be a big benefit, and looks like those trials are also going on at this time. But I cannot say that it definitively occurs. So the adverse effects of SGLT2 inhibitors can be increased rate of urinary tract infections. So release of sugar can actually increase the rate of fungal infections and bacterial infections. And both of these entities, fungus and bacteria, will have a party at the patient's expense. Fungus likes dark, damp places, or it can have urinary tract infections. But there was a significant note in the original study with canagliflozin of amputations and fractures. In further studies, in 3 other studies in this particular drug, canagliflozin, and in the other drugs, the rate of fracture probably occurred because of rapid lowering of blood pressure. Because these drugs make you urinate out the sugar, and the more sugar you have, the more you'll urinate. Irrespective of how much fluid you take in, many patients became dehydrated, dropped their blood pressure, and hence fell and broke a leg or broke an ankle. Unfortunate, but not a direct cause of the drug. It was more a cause of volume loss. So it's very important that these patients in SGLT2 inhibitors take in adequate water. The other side effect on amputation actually did not play out in the 3 other drugs in this class. And it was more of a function that the first study took in what they considered real life scenario, and they took in patients with severe peripheral arterial disease of the legs, including patients that had early necrotic legs or feet. And unfortunately, that didn't play out well at the end of the study, showing a relative increase in amputation rate. That hence had the FDA put a black box warning on this drug, which has been subsequently removed because of the 3 subsequent studies. So there really is not a huge rate of amputation. Yet I will say if patients have severe arterial disease of the legs and have very, very poor pulses, who have multiple ulcers, it may be not the drug to utilize in those patients. And the last thing it can cause, just like the GLP-1s, is diabetic ketoacidosis, and it should not be used in type 1 diabetics. So I've been asked by different providers and patients, is metformin still the first drug to use? That is an option, probably because of cost, but the GLP-1s and the SGLT2 inhibitors can be used as a first-line drug. And the new American Diabetes Association guidelines, which have changed, and how we use the drugs have changed. But yes, it can be used as first line. Again, the big issue will be cost. on not using it first line. But what's interesting is there has been shown benefit of the combination of metformin with GLP-1s or SGLT2 inhibitors have shown an incremental benefit than metformin alone. So there is an added benefit. So we've also found that even if the patient's goal has a controlled A1C, and so different medical societies have different goals, unfortunately. We have not come to a statement amongst internists, endocrinologists, cardiologists really don't treat diabetes, but have used SGLT2 inhibitors as well. But many societies feel that patients over 70 that are more frail may not have tightest control. But let's use the example of the young adult that's 20 that has really good control of their sugars at an A1C of 5, 5.5, 6. These drugs definitely do have benefits. So one, especially in the overweight patient, we may decide to use a GLP-1 to reduce weight, whether it be an oral semaglutide, injectable semaglutide, or maybe we would use tirzepatide in this patient. So there would be a benefit in that patient. We also see a long-term cardiovascular benefit. We have to remember that the cardiovascular disease does not happen in the response of a year or 2 years. This is a 5, 10, 20, 30-year long-term rusting of the arterial walls. The unfortunate part of diabetes is people don't realize that they have diabetes unless it's very high. And most people don't really feel poorly. But what it does, even though you don't see it on the outside, you're actually rusting on the inside. Wherever high sugar goes, whatever that organ is where it sits is where that rusting will occur. Again, retinopathy or increased cataracts in the eyes, heart disease, carotid disease, increased risk of stroke in the brain, kidney disease, or damage in the nerves in the gut or in the legs, lower extremities, or arterial disease in the legs. So yes, there's a definitive benefit. To say that it may prevent congestive heart failure in the future, there looks promise in that, but the studies have not shown direct prevention at this time, but it does look promising. So yes, I think there is an added benefit to using a GLP-1 in the right scenario. The patient with mild kidney disease, you may want to add an SGLT2 inhibitor to their to their um, to the medical regimen to improve outcome or reduce proteinuria or stabilize proteinuria, slowing down the progression of kidney disease. In the obese, again, as I may want to use a patient that's overweight, we want to reduce their weight by using a GLP-1 or an SGLT2, or even better, the combination of both. It's looking at cardiovascular benefits. Patients with known cardiovascular disease, definitively the stronger drug would be an SGLT2 inhibitor to add on, but the GLP-1s have also shown benefit. So we have to look in today's day and age, it's not just knee-jerk. We have to look at the scenario and pick an individualized care, but there is a definite benefit in patients that are already controlled and have adequate control of their A1C. So let's try a case study and let's see how we would use the new two drugs, where would we use them. So I have a 54-year-old African-American male who had a heart attack at 50 years old. His ejection fraction, or how well his heart pumped, which normal ejection fraction is about 60%, was normally 50%. We have concern when it's under 40%. But he had known progressive kidney disease over the last 10 years, and he's considered class 3B moderate kidney disease. He was currently on metformin 1,000 milligrams twice a day. He was on glipizide 10 milligrams and pioglitazone 15 milligrams. He's almost at goal. His A1C was 7.1. And the question that was brought to me as a consultant, what would you consider adding or changing in this regime? The first question is, what is his lipid profile? What is his LDL if he had a heart attack in his 50s? What was his family history? and even more, especially with a fairly well-controlled A1C. And then does this patient have lipoprotein A or Lp little a? So those are things I would check. But since this is a diabetes talk, let's talk about what drugs we would use. And I think for him, the benefit of glipizide is not there because we know over 20 years, the sulfonylurea or glipizide has an increased atherogenic property. It actually, cardiovascular disease increases, as does kidney disease. And this gentleman definitely has kidney disease. I would consider that he did have a heart attack, even though he has a normal ejection fraction. But I did not mention he does have leg swelling and that he cannot walk very far. And on echo, he had a recent echocardiogram that did show normal ejection fraction, but he had what they called stiff myocardium or diastolic dysfunction, or now which is called HEF or heart failure with preserved ejection fraction, meaning that he didn't have lack of compression of that heart. So this becomes interesting. So pioglitazone I would take out, whether he had HFrEF, reduced ejection fraction, or preserved ejection fraction, because he may retain fluid with pioglitazone. The argument I would make very rarely at 15 milligrams, more so in 30 or 45 milligrams, but why make the water muddy? I would take pioglitazone out. And this time I would add, and I would keep metformin in at 1,000 BID as long as he's not having side effects. But I would consider adding either an SGLT2 inhibitor or a GLP-1. So I could use both. I could use either. I would not initiate both at the same time. I would start one or the other. And I think at this point, because of his renal function, I would start the SGLT2 inhibitor first because A, it increases the myocardial pump function and reduces the hospitalization for congestive heart failure more so than the GLP-1 does. And even though the GLP-1s do show renal benefits or kidney benefits, it is more substantial in the SGLT2 inhibitors. So that would be the first drug I would add. And then both do have cardiovascular benefits. So we can add the GLP-1 next. And there is some mild stroke data with both drugs, depending on which drug you use, right? It's all about the drug you use. I've been asked, well, it's a class effect, right? I can use anybody, any drug in this class. And I argue to this date, I do not believe in any class of drug there is a class effect, including in this class, because we have shown benefits of cardiovascular in 2 out of the 4 SGLT2 and T inhibitors. We do heart failure benefits in 3 out of the 4, but the fourth one has shown no benefit at all. And the same thing with the GLP-1s. There are drugs that do not have cardiovascular benefits and do not have renal benefits that were statistically significant. So choose your drugs well and wisely. Second case I have is a Caucasian female that is non-diabetic, 60 years old, had, again, a preserved ejection fraction, normal pump function. But again, she's non-diabetic. In the same scenario, what drug would I consider adding on this patient? And in this patient, because there are studies on 2 of the SGLT2 inhibitors, I would add either DAPA or epanicaflozin to this paradigm and add that to decrease the hospitalization rate in this individual who is a non-diabetic. The only one that's really shown that in non-diabetics to date are those drugs, and I would add one of those 2. So that would give them a benefit of reduced hospitalization, reduced another event of having congestive heart failure and hospitalization for that. The hospitalization rates were markedly reduced, like somewhere along the lines of 32 to 36%, depending on the study you look at. And that's a marked reduction in hospitalization, especially in the diabetic, which in end of life over 60 years old, this is a very high cost, very high hospitalization rate, and just adds poor outcomes long term. In mentioning the benefit of renal benefits of the SGLT2 inhibitors By stabilizing renal function or improving renal function, we may add 16 years to the life of that individual that has a better life without having to go on to dialysis, having worsening kidney disease. And that's a big, big benefit, adding almost 20 years extra to someone's life and having quality of life while you add that on is a big benefit. So again, it was fun talking to you, really fun talking about two of my favorite drugs in the class of diabetes. And now in a disease that was kind of almost a death sentence, now we have drugs that actually have great outcomes, reduces the long-term complications of diabetes, and actually can increase longevity in patients. So choose your drugs wisely. We now have drugs that actually make a big difference. Thank you again.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.info or subscribe to our podcast on your favorite podcast platform.